topic I have prepared like a question and answer. So opioid-free anesthesia. And there is also another term. Of course, this is not the question, part of the question, but just for your knowledge, I have added this also. Opioid-sparing anesthesia. These are the two terminologies which are being used nowadays. In opioid-free anesthesia, where you totally avoid any opioids usage, then you call it as opioid-free anesthesia. No fentanyl, no remifentanil, no morphine, no pethidine. Then it is called totally opioid-free anesthesia. But opioid-sparing anesthesia, you can use small amounts of opioids as a component of the multimodal analgesia system and avoid very potent drugs like morphine and pethidine, etc. Then we call it as opioid-sparing anesthesia. Now, what are the undesirable effects of opioid use for pain relief? That is the reason why this concept has come into play at all. Because the opioid analgesia, which was the original method. Before the opioid administration, what was the method of anesthesia? And what was the drawback of that? When initially general anesthesia was started, what was the method and why they introduced opioids as a part of anesthesia? What did they depend on? They depended on only volatile anesthetic agent. Initially,
yes.
GA was given by open drop method using ether or chloroform and sometimes trilene, etc. All these things produced unconsciousness, but majority of them did not have any analgesic. Of course, ether had some good analgesic property, but other volatile anesthetic agents did not have any analgesic property. This resulted in a severe hemodynamic stress to the patient. Patient had tachycardia, hypertension because they were experiencing pain. Then only the concept of balanced anesthesia was introduced. Who are the people who introduced the concept of balanced anesthesia? Do you know the names of the anesthesiologists who introduced the so-called balanced anesthesia? What are the components of balanced anesthesia?
Amnesia, analgesia, and
hypnosis,
muscle
analgesia, muscle relaxation, or reflex suppression.
Reflex.
Okay? Reflex suppression, analgesia, and hypnosis or amnesia or unconsciousness. These are the components. And
John Lodi, sir.
Pardon?
By John Lodi, sir.
Okay, let it be a homework. Try to go and find out who introduced that concept. And, so the undesirable side effects of the pain relief are respiratory depression, nausea, vomiting, GI tract dysfunction, urinary retention, pruritus, opioid-induced hyperalgesia, the chances of abuse or addiction, and decreased immunity and cancer spread. Okay, so these are all the undesirable effects which they want to avoid. So what are the benefits of use of opioids? That gives a really good pain relief and provides hemodynamic stability because there is no catecholamine secretion because of the pain-induced stress. What were the initial misconceptions which prevented OFA? Why people were not willing to go for opioid-free anesthesia initially? They thought it may not give adequate pain relief and you may need multiple infusions and it may be very expensive. That's what people thought. And for these reasons, they avoided using OFA. Now, what are the drugs commonly used? They can be local anesthetic. Clonidine was also used before dexmedetomidine. Then ketamine, gabapentin, magnesium sulfate, and dexamethasone. So these are all the drugs which are commonly used under the category of OFA. So how does it act? It prevents peripheral and central sensitization. This terminology you have to use in your answer. This prevents peripheral and central sensitization and also prevents opioid-induced hyperalgesia. So which drugs prevent the peripheral sensitization? The drugs like local anesthetic, which completely block the nerve conduction or sensation, as IV infusion or steroid like dexamethasone, NSAIDs. All these things are the drugs which are helpful in preventing the peripheral sensitization. That is, then the injured nerve becomes more sensitive to conduct even a minor stimulus as a painful stimulus. That is what is the meaning for peripheral sensitization. So the site of injury, whatever nerve is there, the sensory nerve, that will react more violently even to a very mild stimulus like a blow of air or a small touch. Even that can cause a severe pain, and that is what is called the peripheral sensitization. And the central sensitization is after the stimulus has been passed on to the central nervous system. There it is uh, um, uh, perceived as a very severe stimulus. Even if a mild stimulus is there, then that is called as the central sensitization. So drugs which can prevent that are induction agents like propofol and etomidate, drugs which blocks substances like substance P like clonidine, dexmedetomidine, or glutamate antagonists like ketamine, magnesium, and gabapentin. So these are all the drugs which prevent the central sensitization. So that is the reason why we are using these two categories of drugs which act on the peripheral and central sensitization. The benefits of OFA are it also produces a good hemodynamic stability. It definitely reduces the respiratory depression. The post-op nausea and vomiting, which is very common with the opioid usage, is definitely reduced. And the GI dysfunction like paralytic ileus, constipation, which are common with opioid usage, is not there. And urinary retention, which is another complication of opioid use, is not there. No pruritus, especially pruritus nose, will not be there. And the chances of addiction and dependence is definitely not there. And no need for elective or emergency ventilation because it doesn't cause any respiratory depression. And because you are blocking the acute pain, it will also prevent the occurrence of chronic pain in these patients. So these are the benefits of OFA. The indications are it is mainly used in cases where patients are already used to opioids like opioid abuse or addiction, or morbid obese patients with OSA, where usage of opioids may cause postoperative respiratory depression. Or nowadays, ERAS protocol is being followed for all major surgeries where you want to discharge the patient as early as possible. So there also, the respiratory depression and sedation, all these things will make the patient stay in the hospital for a longer time if opioids are used. And and also the vomiting in the post-op period will prevent the patient getting discharged early. And persistent pain also will prevent the early discharge. So all these things can be avoided. And onco surgeries, as we said, opioid will encourage metastatic spread because of reduced immunity. So onco surgeries also we prefer nowadays opioid-free analgesia. And patients who develop opioid-induced hyperalgesia, they also benefit by opioid-free anesthesia. And minor surgeries with less post-op pain, definitely you can totally avoid opioids and use these drugs. The contraindications are any allergy to any of the drugs in the composition of OFA, any autonomic dysfunction, patient having already had a CVA or a coronary artery disease or a complete heart block, like all coronary or hemodynamic unstable patients, polytrauma patients, hypovolemia, elderly patients on beta blocker, and ASA4 patients. They are all not fit candidates for practicing OFA. Properties of individual drugs, as we may very well describe. So ketamine forms a very major component of this. It is an NMDA antagonist. It has potent analgesia, amnesia, and opioid sparing effect, and used for analgesia opioid addicted patients. Especially, there are a lot of articles which say that patients who have had abuse of opioid drugs, they respond well to ketamine infusion in a low dose in the postoperative period. And this is now the preferred drug in many procedures like sedation for MRI, pre-medication in children, procedural sedation in acute chronic pain management. And mixing of ketamine and dexmedetomidine has opened a new dimension in the field of OFA concept, and we can because it counter-regulates each other's characteristics. For example, dexmedetomidine can cause bradycardia and hypotension, whereas ketamine can cause tachycardia and hypertension. So they nullify this effect of each other, and it produces a very stable hemodynamic picture. And dexmedetomidine, which is an alpha 2 agonist, which is a sedative and hypnotic, and also a very good analgesic. It has an opioid sparing effect, and it is more powerful than the earlier first generation drug belonging to this category of alpha 2 agonists, like called clonidine. It is used in this dosage, all of you know, 0.2 to 0.7 milligram as a bolus, followed by 0.1 milligram per kg. This transient use, it cannot be used on a long-term basis for prolonging the pain relief, but the initial post-op recovery time, you can use this as an IV plexus axial blockade. It is used for parenteral route also because of its analgesic, antiarrhythmic, and opioid sparing effect. And it is given in doses of 1 to 1.5 milligram IV bolus, followed by 1 to 2 milligram per kg per infusion period of time. And magnesium sulfate is another drug which has again all dilator, antihypertensive, antiarrhythmic, and anti-shivering, very important property. And you start with a bolus dose of 40 milligram per kg IV, followed by 2.5 to 10 milligram per kg per hour as infusion. Dexamethasone, this is also again like lignocaine, you can use it in the immediate post-op period, not for usage the second or third day until. So it is mainly the analgesic, anti-inflammatory, and anti-emetic and anti-shivering properties, having a routine use nowadays. We use it more as an anti-emetic drug. And it can be used in boluses of 8 to 16 milligrams. And, paracetamol used as preemptive analgesia. Very important thing when you use paracetamol as part of opioid-free anesthesia is it should be given as a preemptive infusion. There is no point in using it intraoperatively after the incision is made. That is what we have been doing it routinely now. We use the patient with propofol and fentanyl, and then intraoperatively the first drug we give is the paracetamol infusion after the surgery has started. But the correct way to use it is it can be given the pre-induction period itself as an IV infusion, and then to proceed with the induction, the routine way of using midazolam and glycopyrrolate, propofol, fentanyl, etc. Then use relaxant and intubate or use LMA. So it is ideally given before the incision or the nociception is instituted. Similarly, diclofenac also has to be used like that only, and it has a good anti-inflammatory property. The dosage is 1.5. So these two drugs are given before the surgical incision to have the best effect. And what are the side effects of these drugs used in OFA? Ketamine can cause emergency delirium, tachycardia, excessive secretions, etc. All of you know that. And dexmed, brady, and hypotension, sedation. Lignocaine, if you use it continuously for prolonged period, it can lead to local anesthetic systemic toxicity, bradycardia, and myocardial depression. Paracetamol excessive dosage can cause hepatic damage. And diclofenac is contraindicated in renal failure, bleeding due to antiplatelet thrombospasm in asthmatics. And magnesium can cause hypotension and muscle weakness. The role of regional anesthesia in OFA, that is ideal combination. Regional anesthesia with the combination of any of the above drugs is the best method of producing OFA. So it can be as a central neuraxial blockade or a plexus block or facial plane block or individual nerve blocks. And they can help to minimize the usage of the drugs also. So if you mainly use regional as the intra and post-op pain relief modality, then the requirement of drugs like your Dexam or your ketamine or your lignocaine, whatever paracetamol, whichever drug you plan to use will be required very minimally, because this blockage of nerve by a continuous infusion in the post-op period or intermittent bolus or patient controlled epidural anesthesia, that itself will take care of the majority of the pain. So the requirement of the other drug will be very, very minimal, and you can get away with the without the side effects of overdosage of these drugs also. Okay? But it's about OFA.